have the same implications and risks as if you have sustained hypertension. Now, blood pressure is not stable throughout 24 hours. Does anybody know what the highest reading is, what time of the day the highest reading is usually? Yeah. First thing in the morning, as you're waking up. That's when people have their strokes, their heart attacks, and so on. And so it turns out that the waking process is a very stressful physiological process. Within an hour or two it goes down and then starts easing up in the late afternoon, evenings. And then during sleep it plummets to very, very low levels. And the plummeting of blood pressure during sleep is called dipping. And people with normal blood pressure readings are generally dippers. People who have pre-hypertension, hypertension, kidney disease tend to be non-dippers. What causes high blood pressure, hypertension? Well, the most common cause is what we call essential hypertension. This is a genetic predisposition to hypertension, tends to run in families, is almost predictable when both parents have hypertension. And people more at risk of getting hypertension would be African Americans. As I mentioned, genetics, if you have a strong family history, salt intake, alcohol in certain quantities, and we'll talk about that a little later, obesity, people with serious lipid abnormalities, people with certain personality traits, people who are stressed, anxious, feel panicky, feel that taste in the mouth when anything adverse happens, and certain occupations are predisposed to hypertension. It turns out that people generally in middle management jobs are more at risk of hypertension rather than people at the top of their field, because the thought that the middle management people are under the gun a lot more stress. And of course, obstructive sleep apnea, which is a very, very common condition and is an important cause and treatable cause of hypertension. About 15% of people with hypertension have it secondarily to other diseases, and the commonest one we deal with is kidney disease. So hypertension can cause kidney disease can cause hypertension. Certain medications can cause hypertension, over-the-counter meds like cold decongestants, anti-inflammatory, and this is when we start seeing some of the complications such as anemia, parathyroid hormone going up a little, and when we start having to think about treating anemia with shots of EPO or Aranesp and so on. Stage 4 is advanced or severe. That's when the GFR is between 15 and 29, and this is when we start talking to and making preparations for renal replacement therapy, whether it's dialysis, transplantation, educating the patient, etc. And then stage 5 is when the GFR is less than 15, when it was somewhat traditional to start a patient on dialysis, but it's now recognized that it is not necessary to start dialysis probably until the GFR gets down to 7 if the patient is feeling well. In other words, just because this magic number of stage 5 is hit does not necessarily mean that dialysis is necessary. So there are different kinds of kidney disease, glomerulonephritis. This is when the kidney filters get inflamed, leak protein, and the mechanism of high blood pressure. You can get acute forms, chronic forms. We generally deal more with chronic forms. And these are the folks who get a little salt retention, fluid overload, and diuretics are helpful in these patients. When you have diseases of the blood vessels, such as narrowing of the kidney arteries, both small or large vessels, usually there's no much fluid retention. In these patients, we generally like to use the ACE inhibitors, angiotensin receptor blockers, because the RAS system is activated. 85% of patients with chronic kidney disease are affected. The worse the kidney function is, the worse the hypertension, and it tends to be a worse problem if there's obesity, African American, older folks and diabetics, and both of these mechanisms tend to be active when it's more advanced. Why do people have hypertension? Well, there are a lot of thoughts. There's the blood vessels tend to be stiff from long-standing hypertension. There's a thing called oxidative stress in the body. These are these free radicals which tend to accumulate and block your natural blood pressure lowering lowering chemical, which example of which is nitric oxide. Sometimes these anemia drugs can raise the blood pressure. Sometimes the elevation in the PTH or parathyroid hormone, which is something we monitor, can be a factor. It's interesting that most patients with kidney disease, older people, tend to have systolic high blood pressure. Diastolic readings generally are normal. So you'll have readings of 160 over 70, for example. And if you subtract the 70 from 160, you get what, 90? So when that difference, which is known as the pulse pressure, is greater than 50, that's not good for your blood vessels. It causes shear stress on your blood vessels. So we generally would like the pulse pressure to be around 50 or less. And most of these folks are non-dippers. So the worse your hypertension is, the earlier onset of dialysis. Don't have to be a rocket scientist to figure that out. We know that lowering your blood pressure to 140 over 90 reduces the risk of chronic kidney disease, but probably doesn't help much to lower it lower than that unless you're leaking protein in your urine. And similarly, these class of drugs that I mentioned, the ACE inhibitors, ARB drugs, that's the RAS blockers, are probably protective to your kidneys only if you're leaking protein. We generally use it for most patients, but if you're not leaking protein in your urine, it's probably not that much benefit. The other thing I should mention, that some of you may have been treated with these drugs and your doctor has called you to stop the drug because your creatinine has gone up from 1.5 to 1.7. That is not a reason to stop these drugs, because that often happens. And generally what happens is that the creatinine level tends to level off, come back to baseline in time. And over the long haul, you'll see that patients on these drugs generally do better. But a transient little deterioration in your kidney function happens quite commonly when you lower the blood pressure with any drug, but particularly these drugs. And if 20 to 25% increase is acceptable, over that you probably should cut back. What are our goals of treatment in patients with chronic kidney disease? Less than 130 over 80 is the current recommendation by JNC7 and KDOKI. If you're leaking protein, less than 125 over 75. How successful are we doing this? My friend Glenn Chertow and his colleagues showed that we only do a good job in about 37% of patients.
These are 30%. Are those patients that are being treated? Not the
Yes.
general population?
In general, patients with chronic kidney disease, only 37% are on control.
37%?
37%.
Of those being treated or of the population?
The population.
Excuse me? So if your blood pressure is better than that number, you lower your dose that you're taking of your medication?
Not necessarily. If you're asymptomatic and doing well, no, I wouldn't do that.
How do you know the right dose?
The right dose for an individual patient can vary from patient to patient, but in general, readings of anywhere between 120 and 130 are acceptable. Lower than that, some people tolerate quite well. I'm going to talk about the risk of too low blood pressure in a little while, but in general chronic kidney disease, there's really no evidence that you come to much harm from lowering your blood pressure below that. Unless you're having symptoms, you're feeling dizzy when you stand up or feeling weak or tired, then you may need to back off. But we don't know, certainly in patients on dialysis, we do not know what the optimal blood pressure is.
If you're getting dizzy when you bend down to take photos and you stand up.
It may be that could be one of two things. That could be a balance thing in the ear, so-called vestibular dysfunction, which is usually postural. Sudden changes in your head position causes wooziness. But if that is due to a sudden drop in your blood pressure when you stand up, then you should back off on some of your medications. Especially older folks who have fall risks, get up in the middle of the night, keel over, faint at the side of the bed, break their hip. Not uncommon problem. So, and we certainly know that uncontrolled hypertension worsens kidney disease, especially diabetics. Our usual approach in CKD is starting off with an ACE, A or B, either one or the other. The reason why we have both here is that 10 or 15% of patients cannot tolerate ACE inhibitors due to anybody side effect? Cough. Tickle cough. More common in Asian people and can be a real nuisance. And people have chest x-rays, lung specialists, but really it's a side effect of the ACE inhibitor. And that's often a reason to switch to the ARB. And then the addition of a diuretic is the standard approach to what we used to do. Now, more recently, so we know that if we treat hypertension early and aggressively enough, you can slow down or even halt kidney progression, especially in early diabetic kidney disease. Now, more recently, it appears that the combination of the ACE or ARB plus the calcium channel blocker amlodipine may be a better choice based on certain outcomes in this target study by George Bacris from Chicago. It is very common to need multiple drugs to control hypertension. 3, 4, 5 drugs, not unusual. And the choice of diuretics, if the kidney function is somewhat better than 20 ml per minute on the GFR, we generally use the thiazide. If it's less, we generally use the loop diuretics such as furosemide. And again, as I mentioned, I cannot mention this enough, multiple drugs is often necessary. And there's a drug called minoxidil, which we sometimes use, which is a really effective drug. Now, what about the combinations? I don't know if any people here are on any of these agents, but sometimes we will generally, especially the nephrologist, will generally combine an ACE inhibitor and ARB. And this stems from studies that were done in diabetic kidney disease in the early 90s, which showed that they could be very effective in reducing the protein leak and the blood pressure and the progression of kidney disease. As I mentioned earlier, oftentimes the creatinine bumps a little. You should be aware that there's sometimes a risk of the potassium going up somewhat.
Does the combination relieve the cough probably?
No, it doesn't cancel each other out. And again, in 2003, the co-op study in non-diabetic patients with chronic kidney disease, this combination therapy reduced the doubling of creatinine by 60%. So it was quite effective. However, we are now taking a second look at this because this study called On Target, now each of these studies have names and each letter stands for something. Don't ask me to tell you what they stand for, but they all stand for something. And they found that in patients with diabetes who have diffuse vascular disease, the sicker patients, they actually did worse with these combination drugs. So the message is these combinations are good for many patients, but the patients who are sicker, diabetic, should be very careful because they actually do worse. What about African Americans? The best information comes from the African American study of kidney disease, hypertension. This drug, ramipril, which is an ACE inhibitor, was found to be the best agent. We know that the 30-year risk in African Americans for developing kidney disease with hypertension is double that of Caucasians. Kidney disease develops earlier, gets worse, and there's a much higher incidence of end organ damage. What about dialysis patients? Very common. It's more common in hemodialysis than peritoneal dialysis. Hemodialysis is an intermittent form of therapy. Peritoneal is more of a continuous home therapy. The mechanisms are both salt and water retention and the RAS system. Generally speaking, high blood pressure, hypertension improves after 3 months of dialysis quite dramatically, especially in peritoneal dialysis patients and especially in home hemodialysis patients. Whether you do the slow nocturnal or the daily short therapy is very, very effective treatment. Mostly fluid and salt retention. How does dialysis do this? Well, the main mechanism is by this thing called ultrafiltration. That is the removal of salt and water from the body. And in hemodialysis, it's a convection process through the membrane under pressure. Diffusion, it's because of the sugar in the dialysis fluid that sucks salt and water out of the body. Salt intake is critical, and many patients on dialysis have this insatiable thirst, which is very difficult to deal with. Now we know that there's a range of blood pressure readings in dialysis patients, and low blood pressure may also denote poor outcomes. And looking at patients with readings of less than 120 before dialysis, before going on the machine, generally tend to have a worse outcome in the first year. And what's the reason for that? Probably because these folks have very poor heart muscles to begin with. So they're pumping less and the blood pressure is lower. The optimum blood pressure reading in dialysis, we spoke about the ideal blood pressure in general population. We have no idea what the optimal blood pressure is in dialysis patients. However, a new study looking at 45,000 people showed that you're probably okay between 120 and 160. There was no difference in outcomes if they compared the 120 to 130 folks to the 131 to 160 folks. No difference. However, greater than 160, and as I mentioned earlier, less than 120 is associated with poorer outcomes. Suggestion is that we have pre-dialysis blood pressures of 140/90 and post 130/80. But this needs to be individualized. Some patients cannot tolerate blood pressures of 120 to 130. They feel terrible, they feel dizzy. We've had some patients who have cerebrovascular side effects. And we have to decide whether blood pressure meds should be held or not given on the morning of dialysis. There's this term called dry weight, which is the lowest weight that we safely achieve on dialysis without severe or low blood pressure, cramping, or swelling. So for example, patients come for the hemodialysis treatment weighing 70 kilograms, and they've got some swelling, and the blood pressure is a little high, and you take the weight down with dialysis and fluid removal to 67, 66, and at that blood pressure, At that weight, blood pressure is normal, patient feels okay, not cramping, not dizzy. That is what's called the dry weight. And the dry weight is variable, it changes, it's a moving target. Patients eat well, they gain weight, the dry weight goes up. Patients get sick, get hospitalized, they lose weight, the dry weight goes down. And this process of controlling the dry weight with ultrafiltration is as important as clearing the toxins, the so-called KT/V expression that we use to measure dialysis clearance of urea. Now, what about salt? Let's move on to salt. Salt is becoming quite a topical and very big political subject lately. There's a Salt Institute, which is a powerful lobby in Washington, and they think salt is not bad for you. But looking at the facts, hypertension is more common in populations who eat more than 2 to 2.3 grams of salt a day. That should be sodium. Okay, sodium. It's rare in populations less than 1.3 grams of sodium. Now, when you have patients with hypertension and you put them on salt restriction, you don't lower the blood pressure that much, perhaps 5/3, 5 over systolic, 3 over diastolic. But if you can sustain that salt restriction, it prevents the age-related rise in blood pressure that occurs over decades. So if you look at the area under the curve of blood pressure benefit, it's actually quite enormous. Salt restriction is more important to older people, African American population, obese patients, and patients with chronic kidney disease. Now, why does salt cause hypertension? Well, the conventional thinking is that, used to be, it still is, that excess salt in your diet causes sodium or salt retention, and as a consequence you drink more, you become volume overloaded, and that causes high blood pressure. That's probably not true, and more recent studies suggest that the salt actually gets stored in the kidneys, a special area in the kidneys where the salt gets stored, and it's thought that it combines with a protein in the kidney called the glycoproteins, and this is a toxic substance which blocks this chemical called nitric oxide, which I mentioned earlier, which is your natural blood pressure medication. And that may be the mechanism of, there are other theories as well, but these are the two main ones. This is a very recent finding based on very elegant studies done in Europe recently.
Question.
Yeah.
In the lab test, there is a value called for sodium. So will that value tell us whether you are taking?
No, good question. The question is when you do your blood tests and you get your lab results and you see the serum sodium, which is normally around a very narrow range of 136 to 142, does that tell you whether you're eating or eating too much salt? The answer is no, it doesn't. I will tell you in a little while what the test is to measure how much salt you're eating, but what that tells you is how much water you're drinking. So if you're drinking a ton of water, the sodium level gets diluted. If you're drinking too little, it can go up a bit. But no, it does not. Good question. So what are the benefits? How does salt restriction work? Well, first of all, you get an enhanced response to blood pressure medications. And in particular, when you get a little salt depleted, your RAS system gets activated, and these drugs, the ACE inhibitors, become more effective. Secondly, you tend to lose less potassium in through your kidneys if you're losing less salt. In other words, the salt tends to drive potassium out through your kidneys. Potassium is beneficial if you have hypertension. We know that African Americans respond better than Caucasians to salt restriction. We know that salt restriction reduces cardiac morbidity and mortality. The other side benefit is, well, the more salt you eat, the more salt goes through your kidneys, and the salt going through your kidneys drives through both potassium and calcium. So with a high salt intake, you're also excreting large amounts of calcium through your kidneys. That can predispose you to stones as well as osteoporosis. And so finally, you can reduce the protein leak by reducing the salt going into your body.